Hi, everyone. We're back to healthcare, and we are still on section 9 of H721. And next up, we have Devin Green, Vice President of Government Relations from VOS. So welcome, Devin.
Thank you. Yeah, Devin Green, Vermont Association of Hospitals and Health Systems. And thanks for accommodating me today. I would love to be there in person, but my child is homeschool because she's feeling sick.
So yeah, no worries. You can always join by Zoom.
I feel like this committee could relate.
Yes, yes, we can. As we're all falling apart here.
So I am going to go ahead and share my screen. And can everyone see that okay?
We can. And Devin, when you're done, can you send this to us?
Yes, happy to do that.
Great, thanks.
So before, let's see. Oh, okay. Just to start off, as you all probably know, VOS represents all of Vermont's hospitals, all of which are nonprofit hospitals. And I just wanted to note for folks for future testimony and issues, we represent a lot of touch points in the hospitals, including we meet regularly with the chief medical officers, chief nursing officers, ED medical directors, psych directors, HR directors, IT compliance, chief financial officers. So a lot of different aspects of the hospital. So we are here to talk to you about a variety of topics as it relates to hospitals. Next, I just wanted to start off this conversation. This is, you've heard how much this impacts Vermonters, and that is so true. And I think it has even a more widespread impact just due to Vermont's demographics. And I think through this presentation, you'll see how helping to cover people who are on Medicare and giving them Medicare coverage really touches all different aspects of the healthcare system. So first of all, Vermont has a very challenging healthcare landscape just because we are so rural. We're the most rural state in the nation, and we have a very high aging population. We have the third highest median age in the country. So that already provides a lot of barriers to care. And so we want to try to eliminate as many barriers as possible, especially when it comes to coverage. As you can see from here, the age 65 to 79 age group is increasing rapidly. So that blue line is 2010 and that green line is 2020. And you can see over here, towards the end of this graph, there's a big wide gap because the age is just shifting right over into the 65 plus range. So the 65 to 79 age group had the greatest increase. And it's far outpacing younger people who are coming into Vermont. This, of course, as people mentioned, has an impact on costs. So if you look at the map on the left, that shows the concentration of folks who are 65 and over across the nation. And if you look at the map on the right, that shows the costs. And you can see a little bit, the darker colors are increased costs. You can see a little bit of a correlation there. Where folks are older, you definitely see higher costs to care. How does this relate to hospitals? When it comes to hospitals, if people aren't covered, hospitals do have to cover those costs. So as you all know from years past, we all have financial assistance policies. That means if someone can't pay and they're under a certain income level, particularly within this range that we're talking about with the Medicare Shared Savings Program, hospitals are the ones who have to sort of absorb that cost. And as you can see here, those uncompensated costs have been rising and rising, and the ability for us to meet the needs of those costs are kind of decreasing.
Devin, I'm sorry, can you go back to that slide? And I don't have my glasses, so if everyone else can read it, I apologize. What's the red line on that slide?
The red line is, and it has nothing to do with this necessarily, except for the fact, so that's the dish payment, the disproportionate share payment that's supposed to help cover uncompensated costs. But this just shows that it doesn't cover the costs. And
Right.
so that's where it ends up on the hospital's bottom line.
And I would say it's going down. So there is a, right, this is the red line showing it's going down. So you used to receive more from the federal government for uncompensated. That's going down, but our aging population is increasing and you're not getting reimbursed for it.
Correct.
Okay.
And so, as you all know, ideally hospitals would just absorb these costs, but we don't have the ability to absorb costs at this point. Our hospitals have a fragile financial picture. We have 9 out of our 14 hospitals have negative operating margins. And this picture here just shows how it's a report done for the Green Mountain Care Board in 2021. It shows how Medicaid and Medicare often don't cover hospital costs for our hospitals, and that needs to be absorbed in the commercial rates. And so that means an increase in commercial rates for folks. So if we have people who are over 65 and are unable to afford Medicare and will likely need more care than a younger person or the average person, that could end up shifting the cost over to people who are paying commercial insurance premiums. And then finally, expanding it is just, it will help our patients. It will make sure that they get care at the right place at the right time. We don't want people to forego care, as you heard in those stories, the woman who was saying, don't let the ambulance pick me up. We want them to be able to get the preventive care that they need so that they don't need to be hospitalized. And we also want them to get the care that they need if they do need hospitalization, and to be able to not have to rely on Medicare Advantage plans necessarily. So we have seen with some Medicare Advantage plans, not our local Medicare Advantage plans, that there are much, much higher denials of prior authorizations. There are denials for people moving into skilled nursing facilities or post-acute care, and that ends up impacting the whole system. We've seen today there are only 6 ICU beds available across the state. There are no medical surgical beds available at the University of Vermont Medical Center. And so this little piece is contributing to that patient flow issue that we're seeing, where people can't get into skilled nursing facilities. And to the extent that we can help with that, with better Medicare coverage, we're very supportive of it. We think it'll just be good care for patients. And that's what I have.
Great. Thank you, Devin. If you can take down your slides and then send it to us at the end, that would be great. Any questions for Devin? Okay.
What, maybe you can do this in a percentage. If the eligibility is raised, what impact is that going to have on the problems that the hospitals have now?
I can't say for sure what the direct impact on hospitals would be, but I know, given where we're at in terms of our capacity challenges and our financial challenges, every little bit helps. We need to be looking at everything we can do to try to get people the right care in the right places at the right time, as opposed to foregoing care and ending up in a much more critical situation in the hospital and then being unable to get out of the hospital.
And so your hope is that this would help people get the preventative care or the care they need at the time they're having the issue, rather than now we're hearing that people are waiting because they don't have the money to pay for it.
That's right.
because they get the care.
Right, and may not have to go to the hospital because they get the care.
Thank you.
Any other
Thank you.
questions? Mike?
I wonder if you'd let me make a point.
Absolutely.
So Devin just said.
Can you
I'm sorry, Mike Fisher, healthcare advocate. Devin just said every Vermont hospital has a free care policy. And every Vermont hospital's free care policy would have eligibility for the kinds of incomes we're talking about. And so what we're talking about now is that replacing free care. So someone goes in today, they're one of the people we've highlighted. They absolutely need care. They go get care, they can't pay those bills, and those costs go to the bottom line of the hospital and ultimately are borne by all of us. As opposed to raising these these eligibility rates, drawing down federal dollars and being able to pay those bills that way.
Well, except it won't pay at all, Mike.
Understood?
Yeah,
Understood. So I just wanted, Devin, I don't know if you wanted to sort of
No,
play that.
you said it very well. That's a great point. And that is the point I'm trying to make. That is one of the points I'm trying to make. I mean, I think the other point is even for people who get Medicare Advantage plans, that's also contributing to issues that we're seeing because of denials and issues in the system too. So it's a multifaceted, it could be a multifaceted improvement for care and getting people the right care at the right place in the hospital system.
Good points. Thank you.
I got one more.
Sure.
And I don't want to put anybody on the spot here, but how much would it have to be raised, the eligibility level in terms of the poverty index? What percentage would it have to be raised of the bill? So people wouldn't have to be worried about that. And if you can't estimate it, that's,
I'm not sure I'm understanding the question. How high will we?
how high would we have to go to pay the cost of the bill? Right now, we're gonna do 137% of probably not whatever figure we're gonna use. How high would that have to go to pay it?
Yeah,
About?
I guess I don't know the answer.
Right, because it depends on the service, I would think, right? Depends on what they're,
Except if we're doing one care, you're putting up money out there to take care of the people. I'm just trying to figure, how much higher would we have to go to take care of this whole thing?
May I?
Yeah.
Are you asking, for the record, no one went with this one, are you asking how much the cost shift is? General, or are you asking about just this?
Well, we're gonna take care of people that are up to 26 years old.
so this is specific to 65 and older.
Oh, I mean, 65.
And right now, the proposal that we have in the bill is up to 185%.
Right,
The healthcare advocate has asked us to go up to 225%.
that's right. My question is,
If we
How
go
much?
even higher, how does that help hospitals and providers so that people can pay their bills fully? But I don't think we can answer that, but go ahead, Emily.
Yeah.
Can you just say for the record?
Emma's Office of the Health Advocate. I think it's hard to put an exact number to it, but I will say that when somebody doesn't qualify for Medicaid for age-blind or disabled or the Medicare Savings Program, our advice to them is to apply for hospital patient financial assistance. Because otherwise, they won't be able to pay for their care. So the hope is that with an expansion of Medicare Savings Program, more people would have insurance to give more regular payments to the hospital for their care. They wouldn't have to dip into those patient financial assistance funds. When you see the webpage, you'll see that those stories end that way.
I'm familiar with some of those.
Yeah.
What I'm concerned about is we just heard that X amount of hospitals are in the red right now. So we institute this, how many of those hospitals may come out of the red? I doubt if any of them will.
From this? No,
this
but it would
amount.
help.
It will
It
help.
would help.
But people, I don't want people to think that this is going to be the panacea,
No,
because we got a long way to go.
yes.
Yes.
The healthcare-
And if we lose the hospitals, we're in trouble, big
Yes.
trouble.
this is not a silver bullet, but I think as Mike Fisher was saying, this is a great way to both provide people with coverage while maximizing federal dollars to limit the cost to the state of Vermont and then Vermont hospitals and Vermont commercial insurance payers. Like it strikes a good balance in terms of covering people and doing it in an economically efficient way.
And I want to go back to cost is extremely important in the whole realm of the healthcare system, but this would allow more older Vermonters to get the healthcare they need when they need it, rather than saying, I can't afford, to get that prescription, or I can't afford to go to the doctor for that. And then if the illness progresses, I can't afford the hospital that's going to take me to the hospital, the ambulance that will take me to the hospital. So there's cost, which we must consider. And then there's also the fact that it will help people get the care they need when they need it.
And that's our fastest growing population.
I'm sorry, what was the last part?
That age group is our fastest growing population.
Right. Yeah. Great. Any other questions for Devin? Great. Thanks, Devin. And if you can send those slides again, thank you.
Will do.
All right. Now we have Danielle, and I'm hoping I say this right. Fuco. Hi, Danielle. Fuco. All right.
Hi, Danny Fiacco.
Danny Fiacco. I completely messed that up, and I am extremely sorry. So the Healthcare Assistant Administrator for the Department of Vermont Health Access. Welcome. And I don't think you've been in our committee yet, so thank you for coming. And I didn't know if you had prepared testimony.
I don't have written prepared testimony. I do have, I'm here to, again, for the record, Danny Fiacco. I'm a policy analyst with DVA, and I am here to provide some technical expertise on the bill, technical expertise around Medicare savings programs, what's permissible, those kinds of things.
Okay, great. So I'm going to let you just go, and then we will ask questions along the way or at the end. What do you prefer?
Along the way is great.
Okay, great.
Thank you. And thank you so much for having me. I can say that DVA looks forward to being part of this discussion as well as the larger discussion on H721. I did listen to the healthcare advocates testimony. I did want to clarify what I can speak to today, because I know there's a lot of questions about the funding for this bill. I can talk about how the federal funding and federal match works. There's some differences and nuances with these programs. I can talk about what other states have done. What I can't speak to today is the fiscal impact of Section 9 for Vermont specifically. We know, the DVA knows that the legislature is interested in this, and we are working on that internally as quickly as we can.
Great,
I also
thank you.
don't have estimated numbers yet for folks that might be newly eligible for the program. So just wanted to.
I appreciate that, and we will make sure that we come back to you all for that information. And thank you for those that are working on it.
Yes. So the changes proposed in Section 9 can be done via a state plan amendment. They do require CMS approval. States do have flexibility with income disregards and asset disregards for the Medicare savings programs. I hear that the healthcare advocates proposing an amendment to take qualified individuals to 225% of the FPL. I do not believe that that is programmatically permissible. When you expand QI, you may expand it to the extent that you expand the QMB program. New York, for example, they have a state plan amendment that was approved. They expanded their QMB program by 38% of the poverty level. And then when you look at the numbers and you add 38% on top of 138, you get 186, which is what was approved in their state plan. That is permissible. Maine's legislature and what Maine's looking to do with their programs is also expanding their QI program within the same FPL percentage as their Quimby program. And so that's just something we need to consider, is that I don't believe that it's federally permissible to take Quimby to 150 and then to take QI beyond 200% on top of that. So those numbers are kind of tied together. Is one thing.
Okay, so I think what would be helpful as DEVA is looking at the cost and the population, to understand what we would need to raise Quimby to if we wanted to get to 225% of QI. Q1? QI. So if we can just have some help from DEVA on understanding that relationship, that would be great.
Sure.
Thank you.
We'll do that. It's not in time to do that math right this second, but.
Oh, no, that's fine. Yep, please come back. And we already have some questions. So Art?
Lori, just so I can get my head around that, what you just said, you're talking in section 9.
Yes.
What does 150 have to be raised to get to 225?
That's the question that DEVA is going to get back to us on.
Okay, all right. Yeah, just want to identify it.
Yep. Great. Thank you, Danny.
Yes. So, and the other piece, which I believe the healthcare advocate also alluded to, is that the QI program is funded differently than our Quimby and our SLIMB programs. Quimby and SLIMB are funded at our regular FMAP. That's our federal medical assistance percentage. That's what we get. It's the share that the federal government pays and then the share that the state government's expected to pay. So those two Medicare savings programs are funded at the traditional FMAP, just like the rest of the Medicaid eligibility groups. QI1 is unique. QI1 is 100% federally funded up to an annual funding allocation cap. And so while New York received approval to expand their QI program and it's programmatically permissible, there's nothing that ties that to the fiscal expansion. So there is a good chance that New York may go past their cap. And when you go past your cap, it's 100% on the state to pay for that. So you'll see that currently Maine's programs, before they're expanding, and other programs tend to take, when they increase their MSPs, they increase their Quimby, they increase their SLIMB, and then they increase their QI program, and they keep it at like a 15 percentage point level. New York is the first state that has exceeded this. And so I don't have figures on what that has costing them for calendar year 2023, but I just wanted to give you that information that the way that QI is calculated and funded on a federal level is different, and it's just, potential for additional state cost.
Okay, we have a couple questions.
Just wondered how the cap is calculated. How does the feds calculate the cap?
It is an estimate based on a 3-year average of the number of Medicare beneficiaries in a given state who are not enrolled in Medicaid and who have income between 120 and 135% of the poverty level. So 120 to 135 is the income range for QI federally. What we would be doing and what other states have done is they disregard income above that level in order to effectively raise the income limit, but that doesn't change how the Department of Health and Human Services has to calculate the funding.
Any other questions? Liz?
Thank you. This is really hard so I'm impressed that you can just really do this.
That's easy.
Oh, sure. So I'm just curious about state plan amendments. You mentioned that we would need a state plan amendment in order to do this. Did I get that right?
Yes.
So can you tell me what that entails?
So state plan amendments, the Medicaid state plan is essentially the agreement between Vermont and the Centers for Medicare and Medicaid Services, or CMS, that gives us our authority to run our Medicaid program. So for certain eligibility groups, states have the ability to adopt less restrictive income and asset resource methodologies. That is how Vermont eliminated the asset test for Medicare savings programs back in 2005. We did a state plan amendment. We disregarded assets for Medicare savings programs. And so this is a process where Vermont submits an amendment and enters into a negotiation, and CMS has a certain amount of time to approve the amendment.
Thanks, that's great. And what's the time frame for that generally?
90 days.
Oh, okay, cool. I would just say 3 years. Thank you.
Art?
Yes,
I would say
Danny.
New York took 10 months, so it is possible that it can take longer.
They say 90 days, but may not be 90 days. Yeah. We know how that works.
Yeah.
Art?
Yes, thank you for your testimony. I'm trying to digest all of this. And since we have 3 healthcare advocate folks in here, I'm hung up on Medicare Savings Program. It pays for the premiums and it pays for, and what else does it pay for? I'm sorry.
So the Medicare savings programs, all 3 of them pay your Medicare Part B premium. So that's the monthly premium. For many folks, it's taken out of their Social Security checks automatically. All 3 programs pay this Medicare Part B as in boy premium.
Okay.
The QMB program is much bigger, so to speak. It's better coverage. QMB pays your Part B premium, but it also pays all of your cost sharing for Part B. So essentially, you've got no out-of-pocket costs for Part B or Part A. So your hospital and your Medicare coverage, if you have QMB, sometimes it's hard to tell that you are not a full dual eligible, that you aren't fully enrolled in Medicaid because the coverage is really great and very similar. The only way you would know is if you needed something that Medicaid covered that Medicare did not cover. That's where you can that's where the differences come in. But otherwise, you're getting full payment of your A and B premiums, as well as all the cost sharing and co-insurance.
Okay, and I just want to clarify, not trying to be picky here, but when you say cost sharing, you're talking about out-of-pocket costs at the copay. Is that what you're talking?
Yes. So you would have a deductible on Part B that would be covered by QMB. And once you reach your deductible, you'd have co-insurance. You'd be responsible for a certain percentage of a bill after you've reached your deductible, and QMB covers that. So essentially, yes, if you are a person with Medicare and you're also enrolled in the QMB program, you should have 0 out-of-pocket costs for what Medicare covers.
Okay, so we're talking about wiping out all your medical costs. Is that correct?
Not drug, but yes.
Oh, not drugs, okay, but everything else will be cared for by this program.
If Medicare covers it, yes.
If Medicare covers it. Okay, and QI1 is fed and the other is fed in state. QMB is fed in state. Okay. Is there any sliding scale in here? In other words, doesn't pay for all, but pays for some? Well, I mean, this is our bill. I mean, is there any sliding scale in our bill?
We do not have a sliding scale in the bill,
So
though.
this is going to pay the people that are out of
Up to
increasing the
PL and eligibility.
FPL to include total payment of all that stuff instead of paying for like 50% or
Yes.
25%. We're not instituting any sort of a slide.
Right, so basically, we're not instituting, but we're not changing the program either. So they don't pay today, those that qualify. We're just saying that more people are going to qualify.
Right, but the people that don't qualify today have to pay the whole thing, the whole cost of.
Yes, people who don't qualify today.
But, I don't know, wouldn't it make sense to pay for some of theirs instead of all of it?
These are pretty low income people, but that's the conversation we can have. And one of the questions, Danny, so with this, through this program, can we as a state say institute some type of cost sharing?
I don't believe so, but I can double check that for you.
Okay, that'd be great. And then we do have a couple more questions on the cap. Once you're ready.
Or maybe once I'm ready. Trying to wrap my brain around this. So first of all, before I ask a question regarding the cap, so if we increase the QIMBY requirements and we were getting, our regular FMAP, do the feds have a max federal poverty level that you can increase to keep receiving your regular FMAP?
No.
Okay. So you said that they calculate the QI1, the feds do, based upon the people who have Medicare in your state who are between 100 and 100, and I don't know if you said 136 or 138 of poverty level.
135. The current,
135.
Yep.
So our current. So if we increased our level to 200 and something, that doesn't increase what the feds are going to make the calculation of how much 100% Fed money that they're going to give us. So we already know what our cap is, right? And how close are we to our cap now? How much money are we leaving on the table now?
So what happens with the funding allocation? Got the pot of money, they distribute it based on that 3-year average number estimate. And then there is a reallocation that can happen during the year. So if, Alabama ends up having more, QI enrollees and another state didn't have as many, there's a reallocation process that happens. But I'm not aware of us leaving any money on the table necessarily. I don't believe we've ever exceeded the cap, but it's kind of a federal shuffle to ensure that states are kept as whole as possible.
So we're in competition with other states?
I mean, it's the way that it is, the way that the estimate is broken up is to just try to make sure that the Medicare beneficiaries that would meet the eligibility criteria federally, which is that they're not enrolled in Medicaid and that their income's between 200 and 135% FPL, that each state has enough allocation to cover those individuals. But if the state changes their FPL or expands it, that doesn't change this estimate of how the allocation works.
So when, as Diva is looking at the cost estimates on this for us, is that something you can come back to us and educate us on within this proposal that we have in section 9?
Yes, so any cost estimate would
Okay.
consider that.
Okay, great. So we'll come back to that. Great. Were there other specific points you wanted to, I'm turning it back to you if there's more.
So it's hard to see if there's questions, so thank you.
I think we're good now. Thank you.
Great. So another just kind of quick point, since V-Farm was brought up, there changes to the MSP doesn't change the V-Farm program. The V-Farm programs, the authority for the V-Farm program is in our 1115 waiver. So there wouldn't just to want to make clear that any changes to MSP doesn't directly change our V-Farm program.
Correct, but does moving more people into MSP move them out of V-Farm?
No, you can be an MSP and V-Farm, and many people are. The low-income subsidy, which is the program managed through Social Security that was mentioned, that is, as Emma had mentioned, that V-Farm does require folks to apply for low-income subsidies so that everyone that could be eligible for it receives it. If you are found eligible for a Medicare savings program, you are deemed eligible for low-income subsidy and can be enrolled in it automatically through a data exchange between the state and the federal government. And that's certainly beneficial. The low-income subsidy program federally did expand to 150% of the poverty level beginning January 1st of this year. So V-Farm 1 now aligns with the income limit for V-Farm 1 is 150% FPL, and low-income subsidy is now also 150% FPL federally. So they do currently align.
Okay, that's helpful. Okay, I don't think there's any questions on that.
And Diva appreciates the way that the effective date for Section 9 is drafted. Notice that there's not a hard date. There are also operational and technical implications for the department to making a change like this. So having some time to be able to do that is important.
Okay. And if there's costs associated with the operational and technical changes, I'm sure that will be part of when you come back to us with the cost estimate.
Yes.
Okay, great.
And so, yeah, I think the biggest thing I wanted to point out was the difference in funding. And then the last thing is to mention is SLIMB is being subsumed in this proposal. The other big difference between SLIMB and QI, because sometimes they seem very much like the same program. One, the funding is very different. And two, with SLIMB, you can also be fully enrolled in Medicaid and be enrolled in the SLIMB program. One of the federal conditions for the QI program is that you can't be eligible for full Medicaid. And when we think about the FPLs, it's kind of hard to imagine, are you full Medicaid and SLIMB or QI? That can come up for folks who might be eligible for working people with disabilities. Medicaid for working people with disabilities has a higher FPL limit, but they couldn't be in that and QI at the same time. So that's just one example of the differences that exist between SLIMB and QI.
So we have a couple questions. Alyssa?
No, I'm really sorry. I don't want to backtrack us a little bit, but I just I was looking over the PowerPoint presentation at the other states that have expanded. And some of them have been around at least a couple years, I think. Have any other states not received their funding? Have they exceeded their cap? I mean, I know New York and Massachusetts are new, but Connecticut is not, and Indiana is not. Do you know if are they getting their federal funding?
I don't know.
Okay. Yeah, we'll come back to that when we have some cost estimates.
Okay.
I think that will be, but I think when we have some cost estimates and aligned with the different programs, it will become more clear what we're looking at cost-wise. I do have a question on the SLIMB, and I apologize, Danny, this might be for the healthcare advocate. Why in the proposal are we looking to subsume SLIMB into Quimby? And I apologize if you brought that up during testimony.
I think we were after doing what both New York and Maine have done, and that is to expand Quimby above the level, and therefore, moving, because SLIMBY is a state federal match. And so, we were trying to mimic what the couple states had done to take advantage of all the federal dollars that were available by moving more people, in effect, into the QI1 program.
Okay. So Danny, I think what will be helpful when we meet again is to understand more the unintended consequences of doing that with people who may lose out if we do that. And therefore, what the option would be if we don't do that. How does that affect the costs? Does that make sense?
The unintended consequences of eliminating SLIMBY.
Yes. Like what don't we know that you all know because you run the program that we need to know? Another way of putting it. And you don't need to answer it now, but that's a potential concern.
Okay, thank you.
Yep. Art, did you have a question?
Of my care. What is that Fed state match?
Danny, do you know the Fed state match for the
Does it change?
the state federal match for the?
Roughly.
Are you just talking regular FMAP?
Is it regular FMAP, Danny?
Yes.
Yeah.
It's the regular amount.
Okay, Nolan can tell us. As Nolan's doing that, obviously this is now getting into the weeds of the program. So, which is great that Danny has brought all of this to us. And Diva is going to work on what the cost estimates will be. And then when we come back, we'll have some things on paper that will help us better understand the weeds.
$2024 FMAP is, state share is 43.48%. State share is 43.48% for fiscal year 24. For fiscal year 25, it'll be 42.17%.
Going down.
Why would it go down?
Why does it go down, Nolan?
So similar to what Danny talked about, it's the 3-year average based on the economics of all the states relative to each other. And so one way to look at it is when our economy is getting better, our FMAP goes down. When our economy is worse, our FMAP goes up. So it's sort of a spread out indicator that we're actually doing a little bit better financially than we were a couple of years ago.
Okay. Does that help?
All the states go up and down, they can't go above 50%.
And each state is different.
Every state's different.
Every state is different.
So it's around that number probably all the time?
No, I can do an FMAP presentation another time if you'd like.
Okay, it doesn't, you don't
That's a whole
need
other-
details. I just want to get a general rough idea. It was 2080, that's.
But yeah, I wish.
Yeah,
We have multiple FMAPs, but that's a whole other conversation.
Yeah, that's a whole other.
I get it, never mind.
Danny, do you have an estimate of when you'd have the cost estimates?
Sorry, trying to come off mute. I do not. I'm hoping that it is soon.
Okay, that's fine. We'll check back in. Any other questions for Danny?
I appreciate the ask for having it written down so that we can put it next to what the health advocates have given us. It's a lot of acronyms to keep bouncing.
Yes, exactly. Yeah. So when you present it, Danny, I mean, present it any way you'd like, but what we would like to see at some point is this is what it is for Quimby, this is what it is for SLIMBY, this is what it is for QI1. That would be helpful. But
Certainly.
if there's another way that you feel will help us understand it better, go for it. Leslie?
I'm just curious about other states and whether we can integrate that information with what she's talking about. Is that useful or not? Trying to get a larger picture, sort of following up on what Elizabeth's talking about.
I think with the knowledge that we have from the presentation, my concern is taking DEVA. If you have the knowledge of what other states are doing, great, but I don't want DEVA to take the time to look at other states because we need to work on this proposal. But
Just think about context, I had to have a context for it.
so, but we have the slide that shows what others have raised it to, so that will help us. Great. Thank you, Annie. We really appreciate you being here and walking us through the weeds a little bit, and we look forward to you and your associates coming back to talk to us about the cost. Thank you.
Thank you.
We are done sooner than I thought we would be, so we are going to be done for the rest of the day unless there's things the committee wants to talk about.
We're not doing.
We're moving prior auths to, yes, let's talk about this week. We're moving prior auths to Thursday. So tomorrow is our mental health testimony day. So in the morning, we will be looking at all the various programs that have been put into place over the last couple of years, how they are, have they gotten off the ground? How are they working? Where are we still seeing gaps in the system? So it'll be all about mental health. And then in the afternoon, tomorrow is our joint session with Committee on Education. I believe it will be in the education room, which is down on the first floor. And it's to talk about mental health and funding in our schools. So very different conversation from the morning. Morning will be, what have we put into place? How are we doing? The afternoon will be all about schools. And then we go to the House floor. And then Thursday, we'll be switching to H766, which is the prior authorization, claims edits, and direct billing bill that's been introduced. And we will have Legislative Council do a walkthrough, and there will be testimony on that bill that day. And then Thursday afternoon, we're going to talk a little bit more about mental health for older Vermonters through what's happening in SASH in the state. And then I think that's good for now. Friday will be something else. So we're kind of all over the board this week. Does that help?
Can I ask, we received some questions from our testimony from DEVA. I didn't know if we were going to have a chance to talk about that or.
What testimony?
From Alex,
BAA?
From the BAA, yeah.
From the BAA.
Yeah.
I sent it to you all. I honestly have not read it yet. But we could pull it up.
And maybe not now, just,
Okay.
I don't think many of us have really looked at it, but it's there.
Okay.
I just want to lose track of it. That's all.
Okay, well, it'd be great if there are questions, let me know. Everyone read it on their own. If there are questions, let me know. And I'll look at it too. I wasn't going to go back to BAA unless there are things we need to bring up in the future.
Yeah, I mean, it's not really about the BAA. It's sort of more about how money's spent or how decisions are made about it.
Okay.
Because here they were just talking about expansion of Dr. Dinosaur didn't happen or something along like why, that idea.
Okay, so we'll have to read it and come back to it. Okay. Anything else?